So proceeding further, we will be dealing with the apical 4-chamber view. This is one of the most important views when the hemodynamics is concerned. Many times we may not be able to assess the hemodynamic status, or even we may not get better views or windows of the heart when plaques is concerned or short axis is concerned. And in also emergency situations where the patient has to be dealt with the urgency and he can't went to the lateral position, left lateral position, or in the patients where they are huge body obesity, huge fat been seeing in the body positions. In those situations, the apical 4-chamber and the subcostal view are the two views which will give you the maximum required information in the least of the time. Like less time is required, but you get the maximum information till the patient gets stabilized. So here is the view which cuts the LA, RA, LV, RV and the 4 chambers in the perpendicular view, and you can be getting a beautiful view of the RA, LA, LV, RV and tricuspid and the mitral valve. And if you still get a cranial angulation, then you can get the aortic valve being open, aorta being opened here, and that will be called as apical 4-chamber view. Okay, so we will just compare the two things. This is how actually the apical 4-chamber view will be seen, and it's beautifully will assess you the LA, RA symmetrically, how which chamber is more dilated and which is not, and it will be assessing the LV very well. May not be the apex very well, but still the LV, most part of the LV, the septum, the RV, the tricuspid valve and the opening of the mitral valve into the LV, and if you angulate more cranially, then you will get in LVOT as we discussed earlier. So, but what is important here? What are the structures we have seen and why they are important? See, earlier I told you in the plaques, when you compare the plaques view and the apical 4-chamber, you assess for 2 dimensions, and then you get the 3-dimension view of the LA, how much is enlarged. Then we hemodynamically we come to the LV. Through the LV we will come through the mitral valve. So you will see the mitral valve structure. Here we will assess about the mitral valve prolapse and mitral valve stenosis and rheumatic mitral valve disease, like the hockey stick appearance, the mitral tip opening and the basal mitral valve fibrosis and PML being fixed, and all these things will be assessed in the apical 4-chamber view. And you can beautifully see the mitral valve prolapse being assessed here. Here is the view where we will be confirming the mitral valve prolapse or there, or definition of mitral valve prolapse is done on the apical 4-chamber view. Then comes the LV cavity is very much beautifully seen here, and every possible hemodynamic function of the LV is done from the apical 4-chamber view. If this is collapsing, then maybe gradient across the mid LVOT we can get, because it is hugely collapsing and dehydration can be confirmed. If the LVH is huge and there is a banana septal hypertrophy is there and there is an LVOT gradient across the mid ventricle, then most probably you are dealing with HOCM. There is severe LVH, but there is no other markers, but there is speckle like appearances there. There is huge contrast being like huge enhancement is there. Then most probably you are dealing with amyloidosis. You can be dealing with apical HCM if there is apical is very much thickened. You can be dealing with apical hypokinesia, septal hypokinesia, lateral wall hypokinesia. All these regional wall abnormalities will be seen in this one. Apical clot, thrombus, all those can be seen very well in the apical 4-chamber view. LV is assessed completely in this view, and then the RV and the RA. RV is assessed, usually it is less than 1/3 of the LV. But there are very much criteria, the basal being 1.9, 1.7, 1.1. Those are all the measurements usually done. You can go to the guidelines for those things. Again, the tricuspid valve, here also you can assess very well tricuspid regurgitation and the right ventricular systolic pressure, that is RVSP, can be assessed from here. From this we can measure the right ventricular pressures, indirectly measuring the pulmonary capillary wedge pressure and indirectly measuring the LV pressure or LA pressure for that matter. And also we can see the RA dilatation, we can see the lateral tricuspid valve on the septal tricuspid valve, how they are acting, the tricuspid regurgitation. So primarily the parasternal long axis or the apical 4-chamber view gives you the hemodynamic status of the patient, and very well you can assess the hemodynamic status of the patient from this view. Thank you.